This is the Critical Care Treatment Guidelines CCT Protocol Update 2023. The Critical Care Transport Committee worked on protocol updates in 2022. They focused on Protocol 1108, shock, and created ventilator guidelines. This is a CCT treatment guideline draft for adult septic shock. This is put up here as an example guideline because subsequent slides are going to show you the flow charts. For adult septic shock, A, confirmed sepsis of infection or suspected infection by a lactic acid level greater than 4, or hypotension after adequate IV fluid resuscitation. Administer supplemental oxygen to achieve an SpO2 of greater than or equal to 92%. Inquire about transferring facility obtaining blood cultures. Ensure transferring facility has initiated broad-spectrum antibiotics prior to transport. Administer 20 milliliters per kilo bolus of a balanced solution like Ringer's lactate, preferred if not already complete. And see the note below. Titrate boluses up to 30 to 40 milliliters per kilogram. Recommend a balanced solution of Ringer's lactate, which is preferred. And following above boluses, IV fluid should be continued at an hourly rate or bolus rate based on mean arterial pressures. Consider requesting arterial line placement and central venous catheter placement. Monitor hourly urine output, and your goal is 0.5 to 1 milliliter per kilo per hour for adults. Initiate vasopressor therapy if the mean arterial pressure remains below 65. Consider push-dose pressors if the patient is in peri-arrest to raise the pressure until an infusion can be initiated. For that, we recommend norepinephrine 0.5 mics a minute and titrate up to 30 mics a minute. Add vasopressin at 0.03 units per minute and titrate to a maximum of 0.04 units per minute if norepinephrine or Levophed doses are greater than 20 mics a minute. If norepinephrine, Levophed, or vasopressin are not available, administer epinephrine drip 1 mic a minute and titrate up to 10 mics a minute. Initiate steroids for refractory shock. Refractory shock would be despite 2 vasopressors that hypotension still persists. Choose one. Hydrocortisone, which is preferred 100 milligrams IV, or Solumedrol 125 milligrams IV. Consider blood transfusion if the hemoglobin is less than or equal to 7 grams per deciliter. If signs and symptoms of fluid overload are present, contact medical direction for guidance. For push-dose pressors, epinephrine 1 to 10,000, use that solution, dilute 1 milliliter of epinephrine 1 to 10,000 into 9 milliliters of normal saline, which will give you 10 mics per milliliter. Administer 10 microgram IV push every 2 minutes until your mean arterial pressure reaches 65. For neosynephrine, the first recommendation is 0.2 milligrams IV push every 10 to 15 minutes until the mean arterial pressure is 65. This should raise the blood pressure for 15 minutes. The next choice would be neosynephrine, and you can give that 2 milligrams in an IM form, and this should raise the blood pressure for about 2 hours. Only choose the IM route if you have lost vascular access and the patient remains with a mean arterial pressure less than 65. The CCT treatment guideline, adult septic shock. Flow chart is for a quick reference only. For all medication and dosage details, refer to written guidelines. First, start with confirming infection or suspected infection, which is a lactate greater than or equal to 4, or hypotension refractory to adequate IV fluid resuscitation. Administer oxygen and keep your SpO2 above 92%. Inquire about blood cultures. Ensure broad-spectrum antibiotics have been administered prior to transport. Administer 20 milliliters per kilo balanced solution bolus, either Ringer's lactate, which is preferred, if not already done. We're going to go down the flow chart to the left. If hypotension persists, administer an additional 10 to 20 milliliters per kilo of balanced IV solution. Following IV fluid bolus, IV fluid should be continued at an hourly rate or bolus rate based on the map and urine output. See guideline for assistance. Going down the right-hand side of that chart, Initiate a vasopressor therapy if the mean arterial pressure is less than or equal to 65. See the note in the written guideline. If hypotension persists despite 2 vasopressor infusions, administer steroids. If hemoglobin is less than 7, consider blood transfusion. So for the changes to this guideline from the very first slide, which was very busy, this is now its own guideline. There's an addition of verification of blood cultures and broad-spectrum antibiotics at the sending facility. The initial fluid bolus changed from 20 milliliters per kilo, and you titrate up to 30 to 40 milliliters per kilo as needed. An addition of monitoring urine output has been put in here. The initial pressure has been changed to Levophed from dopamine. Vasopressin dose has been changed to 0.03, 0.04 units per minute and to be started when Levophed is at 20 mics a minute. Epinephrine drips are only used if Levophed and vasopressin are unavailable and the starting dose was decreased to 1 mic per minute. The addition of steroid therapy has been added and an addition of push-dose pressors prior to drips has been added. This is the CCT treatment guideline for pulmonary embolism or obstructive shock. The flow chart is for quick reference only. For all medication and dosage details, refer to written guidelines. Administer oxygen and titrate your FiO2 to keep your SpO2 above 92%. Ensure the patient has 2 large bore IVs or IO. Consider asking for an arterial line. Consider weight-based heparin bolus and weight-based heparin drips. If the MAP is less than 65, consider initiation of vasopressor followed by an inotrope and see the guidelines for medications and dosages. If intubation is required, consider push-dose pressors to prevent peri-intubation arrest. We're going down the left-hand side of the guide here. If the patient remains unstable or worsening, perform thrombolytic checklist. If absolute contraindications are present, then discuss the possibility of ECMO transport teams. Going down the right side of the chart, if no absolute contraindications to thrombolytics, discuss thrombolytic therapy and options with the transferring facility. See the guideline for suggested discussions. If thrombolytic therapy is administered and the patient has a high risk of bleeding, stop at 50 milligrams if the patient begins responding to the therapy. So for pulmonary embolism, it is now its own guideline. There's an addition of pressors if needed, and consider an ECMO team. The CCT treatment guideline for neurogenic shock. Flowchart is for quick reference only. For all medication and dosage details, refer to the written guideline. Identify potential mechanisms, signs, and symptoms for neurogenic shock. Ensure full spinal motion restriction is in place for transport. Ensure the patient has 2 large bore IVs or an IO. Administer up to 20 milliliters per kilo of IV fluid bolus if not already completed. If the MAP remains less than 65 after adequate IV fluid resuscitation, then initiate vasopressors. See guidelines for medications and dosages. Neurogenic shock now has its own guideline. The epinephrine drip's maximum dose has increased to 10 mics per minute. The phenylephrine drip's maximum dose has decreased to 180 mics a minute. The CCT treatment guideline for hemorrhagic shock. The flowchart is for quick reference only. For all medication and dosage details, refer to written guidelines. Apply oxygen and attempt to keep the SpO2 at least 94%. Ensure that the patient has 2 large bore IVs or IO, or the facility has inserted a CVC. Limit non-blood product fluids. Assess for anticoagulation therapy and the need for reversal agents, and see the guideline for reversal therapy suggestions. Administer TXA if indicated and not completed already or contraindicated. 1 gram bolus followed by a repeat 1 gram or an infusion. Review labs if available. If IV fluid or other significant treatment is performed after the initial blood draw, obtain new labs if possible, but do not delay transport to definitive care awaiting on their results. We're going to go down the left side of the chart. Discuss any critical or abnormal labs with the sending facility. Initiate correction of critical labs prior to transport if possible. And discuss with transferring facility surgical options if the patient is too unstable for transport. We're going down the right side of the guideline. If the physician declines permissive hypotension, monitor hemodynamics. Aim for a MAP to ordered or greater than 65. If traumatic brain injury is suspected, aim for a MAP of at least 80. Limit non-blood product fluids. Administer packed red blood cells, fresh frozen plasma, platelets in a 1:1:1 if available, or whole blood. Ensure that the patient blood and IV fluids are in the ambulance or helicopter are warm before and during transport. So the hemorrhagic shock changes. Now it's its own guideline. Maintaining an SpO2 of 94, the rest were at 92. Addition of reversal agents like vitamin K have been added. Normal saline boluses have been removed, and the addition of MTP chart. Warming measures and albumin therapy has been removed. CCT treatment guideline cardiogenic shock. The flow chart is for quick reference only. For all medication and dosage details, refer to the written guideline. Administer oxygen to achieve an SpO2 of greater than 92%. Consider intubation if the SpO2 is not maintained or the patient has an altered level of consciousness. Consider push dose pressors to prevent peri-intubation arrest. Review or obtain a 12-lead, right and posterior views as appropriate. Consider aspirin administration. Consider anticoagulant therapy if not contraindicated. And we're going to go down the left-hand side of the flow chart. Consider differential diagnosis of cardiogenic shock, pulmonary embolus, pneumothorax. Cardiogenic shock masqueraders include sepsis and aspirin toxicity. Going down the right-hand side of the flow chart, initiate vasopressor therapy if the mean arterial pressure is less than or equal to 65. See a note in the written guideline regarding consideration of push-dose pressors until an infusion is available or initiated. If cardiac function remains poor after the mean arterial pressure is corrected, begin inopressor or inotrope. If hemoglobin is less than 7, consider blood transfusion. The cardiogenic shock is now its own guideline. Do a 12 and 15 lead ECG. Consider aspirin and heparin if applicable. There is a differential diagnosis chart. Normal saline boluses have been removed. Levophed drip for initial therapy for hypotension, then inotrope drip. There was no guideline present for inotrope drip. Push dose epinephrine and phenylephrine have been added. CCT treatment guideline, aortic dissection. The flow chart is for quick reference only. For all medication and dosage details, refer to written guidelines. Ensure the patient has 2 large bore IVs, if possible, regardless of central line access. Titrate FiO2 to keep SpO2 greater than 92%. Consider requesting an arterial line in the right radial, which is preferred, and use the left arm for non-invasive blood pressures if possible. Use fentanyl to control pain if no contraindications. Keep the heart rate less than 60 and the systolic blood pressure less than 120 unless otherwise ordered by a physician. Ensure you have enough blood for the length of the transport if necessary. And if the patient is hypotensive, assess for cardiac tamponade, myocardial infarction, aortic valve incompetence, or aortic rupture. This protocol is now its own guideline. You're going to request a radial art line, which is preferred, with the left arm being the arm you take your non-invasive blood pressures in. Metoprolol, cardizem, verapamil have been added to the treatment. Ask specific parameters for heart rate and blood pressure, or use generic heart rate less than 60 and a systolic blood pressure between 100 and 120. Nitroprusside has been added to the treatment. Fentanyl is recommended for pain control. Esmolol drips maximum dose has been increased to 300 mics per kilo per minute, and labetalol doses are now 20 milligrams IV push, and they used to be 10 and 10. The CCT treatment guideline, anaphylactic shock. The flow chart is for quick reference only. For all medication and dosage details, refer to written guidelines. Ensure triggers are removed if possible. Administer 0.3 milligrams of epi 1 to 1,000 IM. Administer high-flow oxygen to keep the SpO2 greater than or equal to 92% and consider early intubation. Anticipate airway edema and the need for cricothyrotomy, which means plan and set up. If stridor is present, nebulize 5 milligrams of epinephrine 1 to 1,000. Ensure the patient has 2 large bore IVs or IO if possible and administer 20 milliliters per kilo of 0.9% normal saline, or lactated ring or bolus if not already complete. Administer epinephrine and see the guideline for dosing information. Consider alternative agents like norepinephrine, vasopressin, and glucagon. Once hemodynamic stability is achieved, begin adjunct therapy like antihistamines and steroids. So the anaphylactic shock changes. The bolus is specified as 20 milliliters per kilo. It used to be 500 to 1,000 milliliters. Benadryl IV dose changed to 25 milligrams. Epinephrine nebulized is used instead of an albuterol or dual neb. You may repeat IM epinephrine. Ritonavir is removed. 0.01 milligram of epinephrine, 1 to 100,000 instead of 0.5 milligrams of 1 to 10,000. Epinephrine drip is now considered. Solucortov, Decadron have been weight-based dosing. Adjunct therapy is delayed until hemodynamic stability has been achieved. Volume control ventilator settings. The flowchart is for quick reference only. For complete details, refer to written guidelines. Confirm endotracheal tube placement. Set your initial tidal volume at 6 to 8 milliliters per kilo of ideal body weight, or match the transferring facility's settings. Attempt to keep your P-plat at less than 30 centimeters of water. Ensure adequate ventilation. Set your initial respiratory rate between 12 and 20 a minute, or match the transferring facility if adequate. Monitor capnography, capnometer, end-tidal CO2 to help guideline the respiratory rate and the tidal volume for adjustments. Prevent atelectasis. Set your initial PEEP at greater than or equal to 5, or match the transferring facility setting if they're adequate. On the left-hand side of the flowchart, consider conditions that may require increased PEEP: obesity, abdominal distension, ARDS, COVID-19, pulmonary edema, pneumonia, and emphysema. On the right-hand side of the flowchart, prevent hypoxia and hyperoxagia. Initial settings are 1, which is 100%, or match the transferring if adequate. After 15 minutes, you may wean your FiO2 by 5 to 10% and attempt to maintain an SpO2 between 92 and 96% to prevent hyperoxia. Assess for ventilator asynchrony, synchrony, adequate patient sedation with a RASS score of a -3 to a -4. The adult pressure control ventilator settings. The flowchart is for quick reference only. For complete details, refer to written guidelines. Confirm endotracheal tube placement. Set your initial pressure approximately 20 centimeters of water, or match transferring facility settings. If the tidal volume requires adjustment, increasing or decreasing pressure directly impacts tidal volume. Ensure adequate ventilation and set your initial respiratory rate between 12 and 20 a minute, or match the transferring facility if adequate. You may have to increase the respiratory rate to maintain adequate minute volume. Prevent atelectasis by setting your initial PEEP at greater than or equal to 5, or match the transferring facility setting if they're adequate. On the left-hand side of the guideline, consider conditions that may require increased PEEP: obesity, abdominal distension, ARDS, COVID-19, pulmonary edema, pneumonia, and emphysema. On the right-hand side of the flowchart, prevent hypoxia, hyperoxia, initial setting, which is 1, 100%, or match transferring if adequate. After 15 minutes, you may wean your FiO2 by 5 to 10% and maintain your SpO2 between 92 and 96% to prevent hyperoxia. Assess for ventilator asynchrony, synchrony, and adequate patient sedation with a RASS score of -3 to -4. Thank you to all the members of the CCT committee. This concludes the CCT protocol update for 2023.